The following video is for educational purposes only. Please use this information with discretion. Our intent is to help you become a more informed healthcare consumer. Ortho University presents Labral Pathology of the Shoulder by Dr. David Eisenhauer. And now it's time to OrthoU.
Hello, I'm Dr. David Eisenhauer. I'm a board-certified and dual fellowship-trained orthopedic surgeon specializing in surgery of the shoulder, elbow, and hand. Today we're going to discuss labral pathology about the shoulder, what it is, how to diagnose it, and how to treat it. We're going to give you some simple home diagnostic tools as well as some simple treatment recommendations that maybe will save you that initial doctor's office visit. First of all, what is the labrum and what is labral pathology? If this is the socket of the ball and socket of the shoulder joint called the glenohumeral joint, the socket is actually much smaller than what's represented here with my hand and my fist. So it's really more like a golf ball on a golf tee. So the socket is much smaller than the ball. So to make that socket bigger and more stable, there's a layer of soft tissue cartilage called the labrum. It deepens the socket and it completely surrounds the socket, making it deeper and helping hold the ball in. If that labrum is torn or partially torn, be it degeneratively, just with age and time, or be it acutely due to a trauma to the shoulder, that causes pain. So if that labrum tears away from the bone, it causes pain. One of the most common causes for a labral tear, particularly in a young patient, is a shoulder dislocation. In older patients, the labrum tends to just wear out and degeneratively tear with time. But in a young patient with a traumatic episode, such as a shoulder dislocation, or sometimes the shoulder doesn't completely dislocate, but the ball will sublux, which means the ball kind of partially slides out of the socket and then comes right back in. That will often tear or knock off the labrum, and that causes pain, typically in the front of the shoulder. When a shoulder dislocates, it tends to come out the front of the shoulder about 90 to 95% of the time. Only 5 to 10% of the time does it go out the back of the shoulder, tearing the posterior labrum. So most patients will have pain in the anterior shoulder. However, they'll complain of pain deep in the shoulder. It'll be somewhat of a vague pain, and they say that it's deep in the shoulder. They tend not to feel it way down the arm like patients with rotator cuff syndrome. They tend not to feel it up in the neck, but pain kind of deep in the shoulder. Oftentimes they'll have some clicking or some catching as they're moving the shoulder. That ball can kind of separate that labrum and cause some popping or clicking or catching in the shoulder. Sometimes they'll have some nocturnal pain or some nighttime pain associated with this. But very often this will be associated with a traumatic event, again, particularly in young patients. So a self-diagnostic tool that you can use to help determine whether this is labral pain or biceps pain or rotator cuff pain is just really pinpoint when your shoulder started hurting. Did you have an injury? Did you have a trauma? Or did this come about more slowly and insidiously? Does it bother you at nighttime? Labral pain tends not to be as bothersome at nighttime as rotator cuff pain, for example. Do you have limited range of motion? In patients with arthritis, certainly severe arthritis, as well as a frozen shoulder or adhesive capsulitis, they tend to have severely limited range of motion. Patients with a labral tear tend to have relatively normal range of motion, but they tend to have pain when they get into certain positions and certain maneuvers. So when patients come see me in the office, in addition to getting x-rays to check for any bony pathology, I'll do a specific exam on them called an O'Brien's test. So we have them lift their arm straight up in front of them and bring it about halfway across their body so that the hand is kind of straight in line with the chest, and then I'll push down on their arm. That oftentimes will cause pain at the labrum. That is the ball of the humerus, so the head of the humerus putting pressure on the labrum, and that causes pain. And then I'll have them turn their thumb down and I'll do the test again. That usually causes more pain. That's internally rotating the head of the humerus against the labrum and pushing on it even more. So patients will usually have pain with this maneuver, more pain with the thumbs down. That's called a positive O'Brien's test. In patients who have had a traumatic episode such as a shoulder dislocation, which was put back into the socket, we can also check for what's called apprehension. So we have them get up kind of into this position. This is difficult to do on yourself, but this position is a position of instability for a shoulder. So if a shoulder is dislocated previously, oftentimes patients will become apprehensive that it's going to dislocate again if they get into this position right here. Most of the time, by far the majority of the time, in these patients, I'm going to be ordering an MRI. And oftentimes that will be a specific type of MRI called an MR arthrogram. That's where they inject dye into your shoulder, and it's going to leak out through any little bitty tears in your labrum. So patients typically will come to see me after they have dislocated or have been having feelings of instability of their shoulder, and we order the MRI and it shows a labral tear. So in terms of how to treat that, some self-diagnostic and self-guided treatment would be in line with many of the other orthopedic pathologies we see, which would be starting out with non-steroidal anti-inflammatories and activity modifications. So patients hate to hear this, but essentially if it hurts, don't do it. If you don't like this position and it hurts the shoulder, don't do it. Certainly don't do it for 4 to 6 weeks and let the shoulder rest. It's important to keep a joint moving and keep it mobile, but try to rest it from any heavy, repetitive, overuse type motions, weightlifting, repetitive job motions, etc.
We pause now with 2 minutes left in the video and ask that you open a separate browser screen and go to MoonlightOrtho.com, where you can quickly register for a free patient account and get immediate access to the final portion of this video, including home treatments and remedies, along with any additional treatments that may be prescribed or recommended in office or via telemedicine, including when it may be time to consider surgery. This also gives you full access to the entire OrthoU video library, highlighting all of the most common orthopedic conditions. Once registered on Moonlight Ortho, patients will have an all-inclusive orthopedic telehealth hub at their fingertips and can pay to be seen by a board-certified and fellowship-trained orthopedic surgeon. Moonlight Ortho is the first and only orthopedic-specific telemedicine practice where patients can be seen online by a board-certified orthopedic surgeon. Via telemedicine, patients can receive X-ray, MRI, lab, and physical therapy orders, along with prescription medications, all within 24 to 36 hours from your time of visit. Thank you for watching, and if you enjoyed this video and appreciate the free advice that our surgeons have offered you, please rate and subscribe.